All right, it is recording. So I did find out how to save Zoom. I have to save it to my computer, and then I have to upload it to my YouTube. And that takes a while because I don't know, maybe my internet is slow, or maybe I'm doing too many things at once. But looks like the 20th meeting is 83% uploaded. So it takes some time. But I am uploading them, so if you want to go back and watch the videos, they should be posted there. I did post a link to the actual playlist itself, and all of the PowerPoints that I've created so far, I'm converting them into video so that you can watch them on YouTube later to make it a little easier instead of going through the PowerPoint over and over. There's also some skills on there. There's skills that I made for an ETT class during this whole COVID thing, so I have to do them by myself, and I don't have anybody near me, so they're not the best video, but it's another resource for you guys. So there's other videos posted on that YouTube channel. It is my personal YouTube channel, so there's other boredom videos on there, so don't mind those. Just skip over those. They're dumb. It happens when you work on nights. We are going to cover the chapters. This is a huge section of an EMT class. This is our bread and butter. Our patient assessment is what we live for. This is what we do. So this is going to be a very long chapter. You guys are given the most time for these chapters because it's what, 9 through 17. So you guys are given the most time to do the homework, do the readings. There's a bunch of different PowerPoints available for you. There should be one just called like assessment priorities, one that is goes over GCS, which a lot of people have a hard time memorizing GCS. It takes some time to memorize them. You already have a third of it memorized if you can just remember AVPU. You're also going to have to start memorizing DCAT BTLS, which is going to be your deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, swelling. I can say it again if you need to, but if you just look up DCAT BTLS, that is going to be every type of trauma that you have. So everything is going to be either deformed. An abrasion is basically like just superficial open wounds to the skin. Contusion is just a fancy word for a bruise. So broken blood vessels underneath the skin that haven't made it, like it's not open, it's a closed wound. Punctures and penetrations, so being stabbed or pierced. That's the difference between your puncture and penetration. So puncture is going to be like a poke in, and then a penetration is going to be like a piercing or going through. You can kind of make them combine the both of them together. Difference between that and an abrasion and a laceration is more like a cut or a slice. A puncture is going to be a poke or like solid. It's not going to tear or rip any of the tissue. And the abrasion, again, is just the most superficial, just kind of the top layers. Think of it like road rash. Burns is not just thermal burns, so like fire or anything like that. It could be chemical burns, it could be radiation burns, it could be cold injuries, so like your frostbite and frost nip. So burns kind of encapsulates any of those. Tenderness is just any sort of pain, so they might not have bruising, they might not have any actual like fractures or breaks or deformities or anything, but it's tender. And then swelling could be a medical problem or a trauma problem. And our body likes to send fluid and nutrients to an area that has been damaged. So you'll get a lot of swelling to injury sites. There's also some medical conditions that cause abnormal swelling, and you guys will learn more about that in the cardiology section of the course. So DCAT BTLS, if you see deformities, you can assume that there is some sort of break in the bone structure. One of them forgot. Mandy should be here anytime then. Oh, Ashley's here.
Hello.
Sorry. Hello. Kind of started with that. Yeah, it's all good. Looks like Mandy got the calendar. There's a mix up with the calendar. Whatever. We got it figured out. We're here. So deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, laceration, and swelling. When you guys do your head to toe assessment, those are all the trauma injuries that you guys are going to find. The biggest and most important part of a patient assessment is scene safety, and then your life threats. Everybody dies from airway, breathing, circulation problems. The first part of your chapters goes over airway. It has a section on suctioning, and with how we have OPAs and MPAs, and you guys can see videos on how OPAs and MPAs can be inserted. So OPA being an oral pharyngeal airway, goes into the mouth, and it essentially just kind of pulls the back of the throat kind of forward. So it kind of lifts the tongue up out of the way. It is an artificial just piece of plastic that is anatomically shaped. So it's kind of like a C shape. You are gonna have difficulties putting it in an adult if you try to go anatomically, because the tongue gets all floppy and flaccid and in the way. So you got to kind of pull it forward and then get the device in. So it's a lot easier to go at like a 90 or at a 180 degree angle, get it in past the tongue, and then rotate it in. It has a section on there about pediatrics, and you're not able to do that. Little kids, infants, newborns, they don't have a hard palate. Their hard palate hasn't developed yet, so it's still soft, and you can puncture through it or penetrate with the OPA. And I don't know if you know this, but right above their mouth is this really important organ. So we don't want to be shoving anything into that. So do not go 180 degrees and then rotate it through. We don't want to scrape that. So with infants and like toddlers, you want to go anatomically correct. If you attempt to put an OPA in, let's say you tried to do it right now, you're not going to enjoy it, and it's going to make you gag. It's very similar to putting your own finger in your mouth. So you want to assess to make sure that people do not have a gag reflex. We're trying to keep their airway open. If you make them throw up, now there's vomit in the way. I don't like to deal with vomit, and it makes it difficult for them to breathe. So you want to assess their gag reflex. One of the last things that kind of goes when we have unconsciousness is our ability to have a gag reflex. People that overdose on alcohol and kind of drown, they still have a gag reflex, but they don't have the ability to be awake. So that's one of the last things that we lose, is that gag reflex. If you touch somebody's eyelashes when they're unconscious and it kind of moves and responds to that kind of stimulus, they still have the ability to have a gag reflex. So you don't want to put anything in their mouth that'll make them throw up, because then you're going to have to deal with suctioning and more difficult time with their airway. So we have an NPA, or a nasal pharyngeal airway. We can put that in if they have a gag reflex. It goes into one of the nostrils, kind of circles through our sinuses, and then goes to the back of the throat. It works very similarly to the OPA, but it doesn't actually go into the mouth. It just hits right above where the mouth is, kind of like where you get most of your like congestion of your like snot and stuff when you're sick. So right up there in that last little back part of your throat. It'll open up the airway that way. It's kind of like a flexible straw. So some air goes through. The smaller that it gets, and it's measured by French measurements. And so the smaller it gets, the smaller the diameter inside is going to be. As it gets smaller, pretty soon it's going to be a solid tube. You cannot breathe through a solid tube, so they don't make pediatric or baby sizes of the NPA. It's only so small that it can go. There's like I said, one of the videos on the YouTube channel, I kind of show the difference between the OPA and the NPA. There's all sorts of other videos on YouTube that you guys can look up that show the difference between the OPA and the NPA, and you can kind of see in your workbook how an airway from the OPA or NPA will kind of pull that tongue forward. More commonly, the tongue is going to be the airway obstruction of choice, and that's because when we go unconscious, it kind of falls back. We don't even have to have a medical problem, and we'll have airway obstruction from our tongue. When people snore, a lot of times it's from their tongue falling into the back of their throat and kind of blocking off the airway. So if you hear snoring, that is an airway blockage to where we need to open it up. You can use the jaw thrust or head tilt maneuvers, and then to assist you so you're not having to hold that head for so long, that's when you're going to put that OPA in or that NPA. Does that kind of make sense, hopefully, to everybody? I hope. It's hard to respond or hard to see. This is the hardest part of my class, or like for me, is understanding if you guys are getting good input from this. So, all right.
That makes sense. I get it.
Sweet. Getting some thumbs up from you guys. So if I have an NPA and it's going to go into my nostril, one of the things that we need to make sure is that we don't have trauma up here. If I've got fractures up in this part of my face, if I stick a straw up there, it could get through some of the fractures and end up in that really important organ that we don't want to poke into. It could also go into different areas that we don't want it. We want it to follow the sinus pattern and go into the back of the throat. So if there's fractures in the face, and it's hard to, you'll see this in your writing of one of the notes, it's hard to simulate fractures when you guys have mannequins or when you guys practice. So you just have to be cognizant of it and remember to look for it each time. Because all of our mannequins, all of our Fred the Heads, they're all gonna have like normal faces. So it's something you just gotta memorize saying that you look for those fractures, and then it's a contraindication to the NPA. So contraindication for your OPA is going to be a gag reflex. You don't want them throwing up. And a contraindication for an NPA, the nasal pharyngeal airway, little kids, because it's going to be that solid straw is not going to get any air through it, and then fractures to the sinuses or to the face. Let's see. So airway, then we assess breathing. So again, going over the life threats, everybody dies, airway, breathing, circulation. As long as you clear the airway with suctioning, so we talked about opening up the airway, suctioning, if you hear gurgling respirations, and it could be from water, vomit, blood, it could be a number of things that are causing that gurgling, you need to provide suctioning. You never want to lose sight of the tip of the suction catheter. And when you do provide suction, you don't want to provide suction on the way in, only on the way out. And the reason that we do that is it could suck to the cheek, and so you're not going to get all the way down to the bottom of the mouth, and it can actually push stuff in. You want to be able to watch it and observe it all the way down, and then you're going to do a sweeping motion all the way out of the mouth and try to get as much gunk as you can. The longer you've suctioned, the longer they are going without breathing. So we don't want to suction for too long. Usually 10 to 15 seconds is the max that we want to do for suctioning, and then we can provide breaths for them and then go back to suctioning. With suctioning, you always want to have some sort of water or container nearby, because you're going to suck up sticky stuff and your suction catheter can get plugged, and then it becomes useless the next time you need to use it. So you're going to suction out the nastiness. You can pull it out, dump off some of the big chunks of stuff, whatever it may be, go to suction some more, and then when you're done, you're going to put it in like a thing of water and clear it out. So you can actually use that suction tubing a second time or even a third time. Suctioning is incredibly important. So airway has to be done, breathing has to be done, and so suction has to be done before anything else. If they've got deformity to their leg, we've got an arm over on the other side of the room, the priority is always going to be make sure their airway's open, suction if you need to, assess their breathing and circulation. Because people can live without an arm, but if they don't have the ability to keep their airway open, they're going to stop breathing and they're going to die. So don't get distracted by the cool traumas. Don't get distracted by any of that kind of stuff. Always focus on protecting that airway and fixing it immediately, assessing their breathing, and then circulation. There is an entire, I think there's 2 chapters that talk about respirations. One of them is more focused on kind of the airway and the structure of the airways and how breathing is done. And then one is actually on the pathophysiology of breathing. There are a lot of videos with Khan Academy that talk about the science behind breathing. We actually have, and there was a question brought up about chemoreceptors in our brain. So the Medulla Oblongata, I love to say it like that because of Waterboy, but the Medulla Oblongata actually is what controls our respirations. The front of it controls, I think the inspiration, and the rear side of it controls when we exhale. How it's done is it registers different chemicals. It registers a pH balance, and we talked about pH balance before in the last Zoom meeting. We have oxygen, and when we exhale, it's CO2. In what we breathe here is 21% oxygen, and every time we exhale, it's about 16% oxygen. And then you've got nitrogen, you've got CO2, and other things in our exhaled air. We breathe in oxygen, it gets into our lungs, it goes all the way through the small bronchioles, gets to the alveoli, which are these little like balloons or sacs. There is an oxygen and CO2 exchange at that point. The oxygen goes in through the bloodstream and feeds all of the blood vessels, gets carried around through the rest of the body. When it gets to the tissue it's supposed to be dropped off at, it leaves, CO2 comes in, flows through the body, gets to the lungs, goes the other directions through the alveoli, and gets exhaled. That's kind of how the mechanism of ventilation works. Oxygen goes in, CO2 goes out. How our body, with the chemoreceptors in the medulla oblongata, it registers how acidic somebody becomes. So it measures that level of CO2. When the level of CO2 starts to increase, because we always have the CO2 on our body. We can't get rid of all of it, just like we have oxygen in. As I'm breathing now, there's oxygen from 4 breaths ago going through my body. So it measures the amount of CO2 in the level of the blood. And if it gets too high, it tells the body to start breathing in a little faster because it wants to get more oxygen in to try to get rid of more of the CO2. When there isn't enough CO2, it'll actually start to slow down the breathing to kind of retain it. Because if you hold your breath, oxygen, so let's say I stop breathing, oxygen that I breathed in like 4 breaths ago is still getting exchanged. It's getting converted into CO2. So that means the CO2 is going to start building up. I keep holding my breath, the CO2 is going to start building up. Then when I start breathing again, I can actually start getting rid of that CO2. Hopefully that kind of makes sense. As we stop breathing, CO2 will start to build and build and build, and it's kind of like the exhaust system in our body. So the medulla oblongata will either increase or decrease the rate of our respirations to control that. Where this comes into play, and I'm not just trying to make it sound like a bunch of science mumbo jumbo, is there are some respiratory diseases that they've had to deal with for so long that their body has adapted to at higher levels of CO2, mainly in your COPD patients that have been longtime smokers or have other chemicals that have kind of destroyed their lung tissue. So emphysema, chronic bronchitis, these people have retained so much CO2 in their body for so long that their threshold is actually higher, which means the medulla oblongata, when my CO2 gets to here, it says, oh, you need to breathe faster, so I can get rid of it. These people have had it high for so long because they've had such poor care with their lungs that the medulla started to increase that level. So it doesn't want them to start breathing until that CO2 reaches their new normal, which is way up here. So these people, they need to kind of have that retention of CO2 to breathe. Otherwise, their body doesn't even want to breathe. Breathing is something that we don't have to think about. It's something that our body automatically does. And so if their body stops wanting to breathe, that could be a significant issue. The book will talk about having people on, like they're on home oxygen. And if we increase their oxygen levels too much from what they're prescribed, it could increase the oxygen in their body, which decreases that CO2 that they need, and they will no longer breathe. It's hard to see if anybody's understanding this. So people with COPD, their retention of CO2 is what keeps them breathing. They have crappy lung tissue, they're not able to get rid of it, that threshold increases, and they don't want to breathe anymore. So hopefully you guys are getting that. I'm not saying withhold oxygen. That is not at all what I mean. If somebody's having a hard time breathing, we need to give them oxygen if they're not able to get enough oxygen. But be aware that people with COPD need to have that increased level of CO2 for them to continue functioning.
So, Bree, was this in response to my question to Ashley today?
I'm trying to answer it. Hopefully that answered your question.
Well,
yeah.
So my confusion is that the CO2 is created in our body, right?
Yes.
We don't ingest it and it passes through and then we get rid of it. So if it's created in our body, then our body knows how much we have based on chemoreceptors throughout our body that measure the CO2 in our blood, right?
Say one more time.
So our medulla oblongata knows how much CO2 we have because of chemoreceptors throughout our body that measure the amount of CO2 in our blood as it's making its way out of our body.
Yes, you should have chemoreceptors in your carotid artery as well as in your aorta.
Right. So where I'm confused is when it talks about the partial rebreather, it says that the usefulness of that, for example, somebody with COPD, where their breathing is stimulated by their level of CO2, how does the body know? How does the partial rebreather help if you're reintroducing CO2 by causing them to rebreathe it? Because CO2 leaves the body from the alveoli when it's basically kicked out into the and they breathe it out, right?
So but then they're rebreathing it back in. So
right, but the process is through osmosis. It goes from the airway into the bloodstream, but the process isn't designed to work in the opposite. So when you breathe in CO2, how does it get into the bloodstream if the process is supposed to be the opposite? Like, how does it get into the bloodstream to be measured so that it can stimulate breathing if the, and I'm going to say perfusion, but that may not be right. But if perfusion is supposed to take in oxygen and expel CO2, how does the partial rebreather facilitate breathing if it's not supposed to work in that direction?
It doesn't just exchange oxygen, and that's why we can do inhalants with drugs because it doesn't just do oxygen, it does whatever we're breathing in. So when we're breathing in toxins, we're breathing in nicotine, anything in that direction kind of diffuses across.
Okay.
But what happens it's supposed to exchange in that way. It's supposed to exchange in that manner. We also see that with CO poisoning. Our body loves to hold on to CO, and it's less likely to get it out. Well, you got it in there somehow by breathing it in. So anytime we breathe something in, something's going to come in and something's going to go out. So when they rebreathe, even though it's not supposed to go in that direction, it just brings stuff in and then tries to get the it's really essentially the direction of blood flow. That's what kind of controls. So as blood goes through the lungs, it picks up that oxygen it's supposed to, and then it takes it out. As blood goes through the cells, it's supposed to drop off the oxygen and then pick up the CO2 on the way out. So hopefully that kind of answers that, because you do absorb anything that when we inhale.
Can I tag a question on top of Ben's theirs? So with a rebreather, wouldn't that cut down on the percentage of oxygen that you have that's being inhaled? So you're diluting the air that's coming in with CO.
And that's why we give the partial rebreathers to patients that kind of need it. We give it to people that are going to be more likely to our COPDers. We give them the partial rebreathers. I don't actually work for any services that have the partial. Anywhere that I've worked, it's either been a non-rebreather, which is going to have like one-way valves to where they're getting just oxygen in. Or they have nasal cannula, which just increases the oxygen, and then they have the regular room air around them. But the point of the partial rebreather is going to be for patients that have COPD, where they need to have that increased desire to breathe. At Park, we do not have partial rebreathers. The Matsuburo has the non-rebreathers and the nasal cannulas. I'm not sure what other services have, but for the most part, those are kind of the go-to is your non-rebreather, because you're going to get the highest percentage of oxygen, and then the nasal cannula, which is what a lot of people with COPD basically just will live on the rest of their life. And that's because they just don't have good exchange. So we try to get as much oxygen as we can in for these people. We just don't want to overload them because they'll just stop breathing. You guys have any like other questions about the partial rebreathers or anything? Or does anybody have a partial rebreather where they work?
Just in our training supplies.
Yeah. We never use it, but it's there to look at. But that's pretty much the reason for it. So hopefully that answered most of your question there, Ben. I don't know what your other question was. If you guys send questions to Ashley, I try to add them to our Zoom meeting. What was the other half? Oh, so breathing, inspiration and exhalation. So our inspiration is usually quicker. It's an active process. So our diaphragm actually has to squeeze, or it contracts, which makes a like negative pressure in our lungs. And so we suck air in. We're not actually like pushing air in, we're actually creating a negative pressure where the air wants to equalize and it goes in. Why exhalation is a longer process is because the diaphragm will relax and that will naturally just let the air flow back out. So active process for inspiration and a passive relaxation whenever we exhale. There are diseases that will alter these speeds. If you've ever done like yoga, there's this really weird thing you're supposed to do where you kind of tighten the back of your throat and it makes you make this weird like lion sound or something. What it does is it kind of blocks off your airway and it makes your inspiration take longer. If you guys do it now, you kind of hold your tongue to the top of your mouth and you try to breathe and you make almost like a wheezing sound just with your upper airways. It'll slow down your inspiration. It makes it a little harder to get the air in faster. When you have upper airway disease that causes constriction of the upper airway, you're not able to get air in nearly as fast. You kind of have to fight that negative pressure. So inspiration is prolonged. So any of the upper airway diseases, let's say you've got swelling from like a burn, or I've inhaled something that's blocking my airway, it's going to take me a lot longer and a lot harder to get that air in, as opposed to prolonged exhaling. You'll see that in your asthmatics because it's more of a lower airway. What happens with asthma is right at the bases, right after the alveoli, their bronchioles get all tight and swollen, which means the air kind of gets trapped behind. A lot of people that have asthma have described the ability to get air in, but they feel like they can't exhale. They feel like it's trapped. And that's essentially what's happening. Is air gets in, and then they actually have to go from a passive to an active process. They have to try to use the other muscles of their body to push that air out. So exhaling takes a lot longer. So upper airway blockage is going to be inspiration that's prolonged, and then a lower airway kind of blockage or issue is going to be the inability to exhale. Does that answer your question, Ben?
Yes, ma'am. Thank you very much.
All right. Hopefully that kind of answers anybody else's question if they had anything like that. So when you see somebody that is having a really hard time breathing out, think of something that's in the bases of the lungs or something that's happening a lot lower. They're having a hard time pushing it out, because normally you shouldn't push. Normally it should just come out naturally. And if they're having a hard time breathing in, think of something that's happening on the upper airway. It talks about normal respirations. I can judge somebody from like a distance, and when I'm approaching in the room, if I see them breathing faster than I would be comfortable breathing, I know that there's an issue. If I see them breathing super fast, they can only maintain that for so long. I also will assess kind of their work of breathing. If you've ever run anywhere and you stop running and you're kind of out of breath and your side kind of hurts, most of us will kind of tripod. We'll lean over, put our arms on our legs, and try to breathe in. What that does is that helps support the muscles on the outside of our ribs to kind of help with our breathing. It helps that diaphragm, because the diaphragm's been working really hard. So those other muscles within our abdomen and within our ribs, we support them by kind of bending over, and it allows that lung to not work nearly as hard. We're kind of bridging across it. So if you see somebody tripoding or leaning forward, you have to kind of assume that they are doing the same thing. They're trying to support their body and trying to get as much air in. If somebody is sitting at home and they were not running track and field and they're doing that, that should be a huge red flag. If they're having that much trouble breathing just from sitting around their house, then they are going to need some sort of assistance. Other breathing issues, we want to breathe for anybody that is too slow, obviously, if they're not breathing fast enough. We can also breathe for them if they're breathing too fast. And I know it sounds weird, but you can actually coach people, or you can take that BVM, and as you push air in, they have a harder time getting it out, which means that you will get them to slow down. We try not to do that forcefully on people that are awake. We try to coach them through it first. If people hyperventilate too long, they will get, I can't remember the name of the reflex. Ashley, you remember the name of the reflex so you get all like contorted? I can't think of it now.
Sorry, I'm trying to find exams for you. What are we talking about?
Hyperventilation syndrome.
Oh, carpal tunnel spasms?
I thought there was something else for it, but yeah, I think it's carpal spasms or something. Yeah, okay.
Yeah.
When people hyperventilate, they will actually start having contractions in their hands, which if you're sitting there breathing and you're hyperventilating, having an anxiety attack, and your hands start to curl uncontrollably, your reaction is probably going to have more anxiety and more panicky, and you're going to increase your breathing more, which is actually just going to make everything worse. You're going to do this for so long until you pass out, but hey, it'll fix. No longer hyperventilating, and your hands will go back to normal. So that's always good. Try to coach these people down first before you try to force breathe for them.
It actually happened to me while I was in labor. It's pretty painful and pretty freaky because you can't control it, and you're trying to like get them to open up. And I had the nurse grab me by the shoulders, and she said, "You're gonna breathe with me." And she just like breathed with me, and I tried matching her, and it worked. I was able to slow my breathing down.
I had a patient that I tried talking down, did not work. When she did pass out, we were able, once she woke up again, we were able to kind of start her off on the right foot, try to start her off as breathing slow when she finally did come to. But when she first initially passed out, we had to go to breathing or putting some oxygen on her and kind of just, carpal pedal spasm. Thanks, Haley. So if you have somebody that calls an ambulance for such a thing where they can't breathe and their hands are spasming, try to coach them through it. It is terrifying for them, and it is something that can easily be reversed if you can get them to slow their breathing down.
That kind of goes with anybody having any sort of difficulty breathing. Even if it's an asthma patient who can't get air in, they'll usually say like, "I can't breathe." And I've started just saying, "You can breathe. You're breathing right now." And then, I don't know, it must trigger something in their brain. Be like, "Oh yeah, I am breathing. I'm just breathing fast." And usually I'll have my EMT1 do that while I'm setting up, the DUNEB.
I've actually shown people the SpO2 monitor, which you never treat your patient based off of the SpO2 monitor, but if you show them that it says 98, 97%, a lot of times they'll be like, "Oh, I guess I can breathe. I guess I am getting oxygen." The reason I say don't treat the SpO2 monitor is it doesn't work well with fingernail polish or cold fingers, or somebody that is had like CO poisoning, because it doesn't read the oxygen amount of their blood, it just reads the saturation. And so it's just telling you that their blood cells are filled with something, could possibly be oxygen, could possibly be something else. And if they're bleeding out, it's not going to tell you that they have a low blood supply. It's just saying that the blood supply they do have is well oxygenated. So always treat your patient and not the monitor. But I definitely do show them like, hey, you are getting oxygen. This is kind of a percent of how much oxygen is in your bloodstream. So you are getting oxygen. I'm going to have you try to calm your breathing down, slow your breathing down, kind of breathe with me. So
Can I
that
just
definitely
add
does work.
something to that?
Yeah. What's up?
So, on top of that is not only trying to talk them down, but for me, it was eye contact. And like, who was that who said, you know, trigger something in their brain? That nonverbal communication also helped them to be like, oh, so don't get distracted by equipment and stuff. Focus on your patient.
One of the first treatments that we do is just our presence. Our presence on scene is a treatment in itself. When people are calling us, when we show up, a lot of times there's a lot of just relief in their anxiety. I always put patient contact on my report as part of my treatment. That's one of the first things I do on my interventions is patient contact, history, and exam, because my presence there has had some sort of effect on them. And having that nonverbal communication with them can absolutely change their whole perspective on what's happening with them. So good point there, Rose. Let's see. So chapter 11 talks about scene safety. Scene safety is not just something that happens at the beginning of the call. From the initial dispatch out to the first time you get on scene, to the end of the call, when you have already dropped the patient off, you have to have awareness of what's happening around you, because at any time things can change. Traffic never seems to go the way that we want it to. Weather never seems to go the way that we want it to or need it to. In fact, with traffic, people always do the one thing you don't want them to do, like the second you don't want them to do it. What's wrong with exam 3, Ashley?
Nobody can see it.
What the heck?
I'm trying.
Okay. That's
Or at
weird.
least I've had 2 students tell me they weren't able to find it. It's in the grade book, but I also cannot find it in their assignments.
Okay, awesome.
It's unrelated to saying exam 3, but I've been having issues with the website. Like last night, like in the middle of reading, the website just crashed. And I had to reset my computer and try to log in again. And it's been acting really slow. So I don't know if it's my internet or if it's just the website itself.
I have not had any issues. For some reason, I can just stay in all day. And it rarely ever kicks me out. So I don't know. But I also have extreme issues with my YouTube and Zoom. So I'm having issues on another side of things.
I have the same issue, Chelsea. Yesterday, specifically.
Is it kicking a lot of people out?
Yeah, I was on around like 8, 9 o'clock last night, and just out of nowhere, it kicked me out completely, and I couldn't log back on at all. And I ended up just shutting off my computer and like, yep, that's the break for tonight.
I'm wondering if it's just the My Brady website. I'm sure the whole country has switched to My Brady Online.
Yeah. Well, I will try to also resolve the exam 3 ability to see it, because it should be already up saying that it's able to be seen. But I will work on that when we are done with our Zoom meeting. Essentially, you guys don't have to get it done until Monday. That's when it's due, and then it's got like a few day kind of grace period in case you just need some more time. But Monday is technically its due day, which I know is a holiday. Let's see. Chapter 12 is your general impression. Go with your gut. If you walk around the corner and somebody looks like caca, and you're like, oh my God, that person looks really bad, go with that gut. That pucker factor can tell you a whole lot. That's that sick or not sick. That's the sit on scene and try to fix them or get them the heck out of here because you don't want to see them anymore. You want somebody else to take care of them. So your general impression of the patient, as well as getting your AVPU. So are they alert? Do they respond to a verbal stimuli? Do they respond to painful stimuli, or are they unresponsive? And I see a lot of confusion with people when they come up to like a scenario, when you guys get to do your skills, they'll say, hey, are you okay? And the person will moan, and they think that the moaning is a verbal response. Or let's say I do a sternal rub and they moan. It's not their moaning that makes them a V on the AVPU. It's your verbal stimuli that makes them respond. If you walk up to a patient and you're completely silent and you just walk up to them and they start like moaning, that doesn't mean that they're verbal stimuli. If you have to touch them and do some sort of painful or touch response to get them to moan, groan, move around or anything, that's painful. A lot of people will just think that the sound that they make is the response, and it's not. So you get on scene. If they look up at you the second you get there, they respond to your presence just with you there. That is going to be like an alert response. You never want to touch them until you've actually expressed some sort of sound or verbal stimulus. Because if I touch them and I say, hey, are you okay? And they moan, was it my touch or was it my speaking to them that made them respond? So as you approach the scene, announce yourself, hey, are you okay? Can you hear me? They don't respond to that. Then you can touch them. Hey, squeeze them, poke them, prod them. If they respond there, that's the painful response. If you have talked to them, you've pinched them or done a sternal rub or a trap pinch, and they still haven't responded, that's when they're going to be unresponsive. So it's not how their reaction presents, it's what stimulus you gave them to promote that reaction. There should be a couple of videos in your book that talk about AVPU. And then, like I said before, I did make a PowerPoint just on GCS, which is more thorough than your AVPU. AVPU is down and dirty, just quick. They're alert, they're altered, they're unconscious. Let's see. So general impression and AVPU. You're going to do that at the beginning, get your ABCs done. Once you're done with your ABCs and checking life threats, you're going to go into vitals. There's lots of different videos on how to take a set of vitals. Your most important vital is actually their mentation. Going off of how somebody reacts and how they're thinking is going to tell you a lot more. They can have a good blood pressure and they started getting confused. They can still have a good blood pressure, but they weren't confused and now they are. That's more significant than the fact that their blood pressure hasn't changed much. So always get an assessment of their mentation along with the rest of your vital signs. And you always want to get more than one, preferably 3, but at a minimum 2. And the reason is you can't tell if your treatments are doing anything for or against the patient. If you only get 1 blood pressure and then you take them to the hospital and then they get a blood pressure a while later that's really, really low, like how long has the patient been declining? We don't know because we didn't get a trend. So you always want to get at least 2 sets of vitals. And a lot of people say, well, I didn't have time. Absolutely, you did. You can get a cap refill. You can get a respiration rate. You can get just an appearance of the skin. Like, look at just the basic things. If you are so busy that you can't get a blood pressure cuff out, there's other things that you can do that are part of your vital signs. Getting a respiration count, or even just their work of breathing every like 5 minutes, and a cap refill, if that's the only thing that you can do because things are just going too crazy and hectic, you have to document that. At least you have some sort of trend. Definitely preferred to have a full set. So your blood pressure, your respirations, your pulse, SpO2, temperature, skin, pupils. There's so many different things that encompass vital signs. You don't have to get them all every time, but you definitely need to get something to compare a baseline and then throughout your treatment. Let's see. I already talked about treating the patient and not the monitor. You want to look at the overall picture. You want to, maybe their heart rate is up because they're just kind of an out of shape person and their heart rate's always a little elevated. Or they're a marathon runner and their heart rate's always wicked slow. They're sitting right at like 50 beats a minute, and that's normal for them. So yes, the monitor's saying like, oh my God, they're at 50 beats a minute, but your patient's fine, your patient's stable. They're talking to you, they're interacting with you. They're warm, pink, and dry. They're not confused. So treat the patient and not the monitor. Chapter 14 covers your assessment. So I talked about DCAP BTLS before. Lung sounds, there's different types of lung sounds. If you can't memorize what the lung sound is, or you can't remember like which one you need to call it, at least let people know that it's noisy or it's absent. There's different ways to describe it. If you just say, hey, he's got really loud or really noisy lung sounds on the left side, that'll tell us there's maybe fluid, mucus, there's some sort of thing going on the left side. If you can't determine if it's rales, bronchi, wheezes, anytime in your questions it talks about like a whimsical or musical sound, it's probably talking about wheezing. The reason I don't consider it musical or whimsical in any way, but the reason they call it that is because when you have wheezing, the small airways in the bases of your lungs get all tight. And when you have an airway get tight, think of it like whistling. You purse your lips together, you make it a lot tighter, you whistle. So if your teeny tiny airways at the bases of your lungs all get teeny, like get tight up, then they're going to start whistling. So which is where you get your like whimsical or musical sound. When you get fluid in your lung, the thicker the fluid, the more like thicker it's going to sound. So think of like mucus. So think of blowing bubbles in like chocolate milk, not chocolate milk, but like a milkshake, super thick. It's not going to be a lot of different bubbles. That's going to be more of your mucusy, bronchi, thick grossness. If it's watery, think of blowing bubbles in milk or blowing bubbles in soda or water. It's going to have more fluid to it. It's going to have a lot faster bubbling sound. That's going to be water in the lungs or crackles. You can get water in your lungs for a couple different medical reasons, and you guys will learn more about that in like your cardiopulmonary section. Just recognize in your assessment what noisy lung sounds are. Basically from like here on out, you guys should be listening to other people's lungs. Whenever you get a chance to listen to healthy people's lungs, sick people's lungs, because if you listen to it all the time and you're like, yep, normal, 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 the second you hear something that's not normal, you're gonna notice it. And you're not gonna be like, oh, do I hear something? I don't remember what this is. Even if you don't remember, you'll at least recognize it's not normal. It's not something that you've listened to before. Same thing with your abdomen. people's abdomens kind of feel all different, but they're normal. So if you assess every patient's abdomen that you guys see, then you're going to be like normal, normal, normal. And the second you get one that's not, you're going to be like, whoa, I don't know what that is. Something's wrong with it. Abdomen's not normal. Besides the decap BTLS, you also want to check your abdomen for distension, which is going to be like a bunch of air in there, or rigidity. Rigidity is blood that's coagulated in the abdominal cavity. So it is something you're not going to find at the very beginning of somebody bleeding out. It's going to be something that you're going to notice after some time that they've been bleeding. So we want to assess that at the beginning of our call and throughout, because you might not notice it at the beginning, but they've been bleeding for the past 15 minutes. We want to assess the abdomen to see if anything has changed. And that's where you get into your reassessment. With your reassessment of your patient, you're comparing what you found first and then seeing if anything has gotten better or worse. The last part of your guys's module is communications and documentation. Communications talks about radio use and phone use. There is a discussion board that talks about a radio report. You guys will be given patient information, and it's going to be sporadic. There's going to be stuff that should be said at the beginning of your report, near the end, and near the middle. It's all going to be mishmash order. What I want you guys to do for your discussion board is try to write something up that you would tell your clinic or hospital or wherever you're taking your patient. Try to get it down to like 30 seconds to where you're like, I've got a so-and-so patient complaining of this. We're this far out. This is what's going on. This is the interventions I've done. These are the vitals. Do you have any questions? So laying that out. So chapter 17, there's also a PowerPoint for it that talks about communications and documentation. This is where you're going to learn more about your SOAP notes on how to write them. So you guys did Patty. When you guys do your deadliest catch one, and then there's one more later in the later chapters, you're gonna want to kind of start going over your SOAP notes on how to write them, what's included in your subjective, what's in your objective, and writing those out. Also, from here on out, you're gonna try to think of ways that you can paint a picture in less than 30 seconds for somebody. Tell me what's happening with your patient. If you are doing CPR on somebody, don't start your conversation with, we have a 50-year-old male who was complaining of chest pain and some shortness of breath, and we gave him some nitro and we put him on oxygen. An ALS person started an IV, and oh, by the way, we're doing compressions. Always start with like the most important things. We have a 58-year-old male, we've defibrillated, doing active CPR. Like start with that. Start with the things that are pertinent. Also, I don't care like what kind of medical history they have unless it's pertinent. Remember, you have very little time to do these radio reports or phone reports because they don't want to be on the phone forever. They're going to be trying to get stuff ready. The whole purpose of the phone report or radio report is to tell them you want a cardiologist, a neurologist, a pediatrician. You want some sort of specialist at the bedside, or they need specific equipment. They're going to need to get a CPAP machine. They're going to need to get other equipment involved. So you're trying to paint a picture real quick. So when you get there, they're ready. They have a room. They've got this specialized equipment at the bedside ready to go. So it needs to be short, sweet, to the point. No additional fluff. Get them the information that they need to get the job done, as well as an idea of how the patient is going to fare for them. So if the patient is headed downhill, like they're getting worse, you need to describe that the patient's not responding well to treatments, the patient is going into shock, some sort of way to describe that. Any inputs on your end there, Ashley, about radio reports or phone reports?
You don't get paid by the syllabus. a lot of students will just talk and talk and talk. And Bree said it perfectly that, you know, make it short and sweet and the most important things.
Are you guys able to see the notes from the instructor on your guys' e-text? Sweet.
I can't see them on the, if it's from a remote device like a tablet or a phone, they don't show up as easily. They do show up on the computer though.
Okay. Yeah, I don't know if this this website's super friendly on mobile devices. Do you does it work on an app, or are you just using the website on your mobile device?
It was the app and the link that you sent in the email about downloading the app, and I can get the whole text and everything. That's fine. It's just I see that it's been highlighted, like the instructor highlighted that section, but I can't click on it and see what your notes are.
Okay. So maybe it just doesn't work well on the mobile stuff. But if you guys can see, I try to put very similar to what these Zoom meetings are, kind of tidbits and thoughts on certain topics that are in your e-text. So make sure that you look at the PowerPoints that are available to you guys. Assessment one, the GCS one, there's a communication one. There's additional resources out there that you guys can use. Khan Academy has some awesome stuff that covers how ventilation works inside of our body. That kind of helps out with that anatomy and physiology. We will work at getting this exam up for you guys to be able to use. Try to get it in like Monday. We'll have another Zoom meeting. I think it's scheduled for Wednesday. So you guys can get this third module done. The reason we're having it done so early is so you guys have a lot more section or a lot more time to get this this studying in, because it is a large module. Do you guys have any questions? Any notes written to you, Ashley?
Nope, just about exam 3, but.
Okay. Well, if you guys don't have any other questions or anything, we'll let you guys go for the night, and good luck with exam 3. Again, you can ask us if you guys need some more clarification or other questions on these chapters. Feel free to ask us. I have a lot of other like notes that I can send out to things, but for the most part, I think I tried to cover it as much as I could with the PowerPoint presentations and the notes on the e-text. And that's all I got for you guys tonight.